Good morning. I am Aiden Bernice Timbol from the Philippine General Hospital, and I'll be presenting our study entitled The Thrombolysis in Myocardial Infarction, or the TIMI Risk Score for STEMI, a validation study among Filipinos for predicting in-hospital mortality. In the Philippines, cardiovascular disease was the leading cause of mortality in 2009, with acute myocardial infarction being responsible for 44%. The risk of death is highest before hospital admission, and this risk remains high after admission, with up to 7% of patients dying prior to discharge. Being the most severe spectrum of ACS, patients with STEMI have a relatively high incidence of short-term cardiac events. It is for this reason that management of STEMI requires careful assessment prior to decisions regarding therapeutic interventions, triage, and allocation of resources. The different combinations of pharmacologic treatment and invasive strategies are associated with different benefits and risks, which frequently differ according to the patient's baseline clinical profile. Hence, international and local guidelines recommend the use of risk scores for clinical decision-making. Braunwald and colleagues derived the important TIMI risk score for STEMI from the INTIME-2 trial, a double-blind comparison of fibrinolytics for the treatment of STEMI. This is a simple risk score based on 8 clinical indicators that can be used at bedside for risk stratification of patients at presentation. Assessed and validated in multiple clinical trials of fibrinolysis, this risk score has not yet been validated in a Filipino population. It is for this reason that our study aims to determine the prognostic value of the thrombolysis in myocardial infarction, or the TIMI risk score, for in-hospital mortality among adult Filipino patients with ST elevation myocardial infarction. Adult thrombolyzed STEMI patients were included in this study. Relevant data was extracted by chart review, and for missing variables, a point value of 0 to the total score was assigned. Multivariable logistic regression analysis was used to determine the association of each variable with in-hospital mortality. Indices of discrimination and calibration were used to assess the performance of the risk score. Discrimination was based on its ability to determine the risk of death during hospitalization. This was expressed as the C statistic, with a value of more than 0.75 having a meaningful discriminatory ability. Calibration describes how closely the predicted rate derived from the INTIME-2 trial approximates the actual observed rate. This was tested using Pearson R correlation coefficient with a value of 0.8 to 1, showing strong to perfect correlation. Our study included 364 thrombolyzed STEMI patients. The only variable missing in the 7% of population with incomplete data is weight. The average age of the population was 57 years old, mostly belonging to the younger age group. Majority of the patients were male, and over half of the population had a weight below 67 kilograms. More than 70% had a history of smoking and alcoholic beverage intake, and hypertension was the most common comorbidity. The most common infarct location was the anterolateral wall, followed closely by the anteroseptal wall. 2/3 of the patient presented with KILIP class 1, and majority of the study population had a higher systolic blood pressure and a normal heart rate. Majority of patients were thrombolyzed more than 4 hours from the onset of chest pain, and the largest proportion of patients had a risk score of 3 with a median score of 4. Now, comparing our results to the original validation cohort of the INTIME-2 trial, in this study, patients presented with STEMI were younger, and male patients constituted more than 3/4 of the population, which was comparable to most recent studies supporting a higher risk of ACS in the male gender. Taking into consideration the complete data set, more than half of our patients had weights below 67 kilos, which may be explained in part by differences in body size and physiology between Caucasians and Asians, Filipinos specifically. Clinical risk factors of this study showed a higher smoking status and more chronic conditions such as diabetes and hypertension. And presenting characteristics in our study was overall more severe, having a lower systolic blood pressure, higher heart rates, and poorer KILIP classes at presentation. This may be explained by the risk factor profile as well as the contribution of different high-risk features of STEMI that may vary in local population groups such as ours from that used in international trials. This table shows the risk relationship between in-hospital mortality and each clinical indicator. In the in-time 2 population, selection of risk indicators was based on their relative prognostic contribution in the full logistic regression model. In our study, age, systolic blood pressure, time to reperfusion, and killit class were found to be independently associated with in-hospital death. This may be due to the relatively high proportion of patients thrombolized more than 4 hours, with majority belonging to the older age group. This figure shows the percent incidence of in-hospital mortality of each TIMI risk score. The overall in-hospital mortality was 16.48%, which was considerably higher than that observed in other validation studies. Here, a significant trend of observed mortality rate can be seen for each increasing risk score. After application of the risk model for prediction of in-hospital mortality, a strong graded association can also be seen, with a significant, nearly 40-fold graded increase in risk between patients with a score of 0 and those with a score of 8 or higher. Test for trend was done on both the observed and predicted rates of our study population, which showed a very significant p-value. The main objective of this study was to validate the prognostic value of the risk score. In our study, a very good model calibrate discrimination was noted with a C-statistic value of 0.81. Comparing our results to the in-time 2 cohort, the study's capacity to discriminate even performed better than the original development step. Furthermore, our result yielded a higher C-statistic compared to an external validation study in the National Registry of Myocardial Infarction by Marot et al., which also revealed a score performance comparable to the in-time 2. Calibration of this study was also very strong. The observed mortality rates derived from patients in our study were strongly concordant with the risk estimates derived from the validation cohorts, with a Pearson R coefficient value of 0.92. This validated the use of TIMI risk score in accurately stratifying STEMI patients in our study population. In summary, the TIMI risk score for STEMI is valid among thrombolized Filipino patients with ST elevation myocardial infarction and can be used as a practical and effective bedside tool for risk assessment. The following are our recommendations. Thank you for your kind attention.
Let's start our open forum.
The comment is that it's a well-done study. I think the methodology and everything was very clear-cut. I like the way you presented the data as well. So I think the agreement is that your cohort agreed quite closely with the original risk stratification. Since you're doing it specifically for Filipino, you may want to fine-tune it to say that maybe some scores have more weightage than others in your sub-study subsequently. I think that's one useful thing. And knowing that there may be a significant delay, you may want to look at delays of longer time, maybe 6 hours as well.
Yes, sir. Thank you for your comment.
Do you do that in routine clinical practice now? It means you score the patient using a TIMI risk score?
We still do it because more for my hospital particularly, we've been doing medical reperfusion strategies, and so it helps us risk stratify our patients regarding their need.
In what way? Meaning, if you find that the risk score is high, is it then shunted towards a PCI strategy, or is it still continue thrombolysis and watch them more closely? What is the impact?
Well, actually, the TIMI risk score for STEMI would not give you a categorical yes or no answer towards each clinical scenario. It instead provides patients, the family, even the physician, a more informed sense of the probability of outcome. So a higher score would mean a higher intensity treatment that would probably give a better sense of outcome.
So a comment about all these scores, whether it's NSTEMI, TIMI, or GRACE score, is that we have a lot of scores for this subgroup ACS which predicts mortality,
Yes.
but there is actually no study that predicts a strategy using
Yes,
scores.
sir.
Meaning, GRACE score high, intervention then predicts better outcome.
Yes,
There
sir.
is actually currently no evidence-based study pointing
Yes,
in the
sir.
direction. So I think it's mainly for, like, say, prognosis.
Yes,
But
sir.
for therapy
Prognosis.
changes, I'm glad you answered me that way. So.
Okay, if we don't have any more comments. Thank you very much, Dr. Timbong. So thank you very much to our panel of judges for their comments and their suggestions. Thank you very much and congratulations to our contestants. Most of your studies really are all about ACS, and these actually are ongoing in a larger scale in our PHA ACS registry.
Congratulations in advance to all the contestants. So the announcement of the winners will be done during the closing ceremonies on May 26. Okay, all finalists are requested to attend the awarding ceremony. Thank you very much.